Hello everyone, my name is Jen Nolan and I'd like to welcome you to our webinar this evening. Tonight's webinar is the last health professional webinar we will be offering for the foreseeable future, although recordings of all our webinars will be available on our website. Starting next year and in line with Musculoskeletal Australia's focus on empowering consumers through education and support services, we will be offering a series of webinars for a consumer audience. A list of webinars should be on your screens now, and we will be enlisting your support to inform your clients and patients about the webinars. Further information will be on our website shortly and will also be sent to you. The first couple of webinars will definitely be offered free of charge, and pending sponsorship support, we hope to offer all webinars at no cost to participants. Before introducing our presenter for this evening, I have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you're listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of his presentation, you can type questions for him at any time. And I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Summer Time. I'd also be grateful if all participants could take a moment during question time to respond to our feedback survey. Our presenter for this evening is Dr. Geoffrey Littlejohn. Jeff is Professor of Medicine at Monash University, Director Emeritus of Rheumatology at Monash Health, and Adjunct Professor at Edith Cowan University in Perth. Jeff has published extensively on many aspects of fibromyalgia and has presented locally and internationally on the topic over many years. Without further ado, I'll hand proceedings over to Jeff. Thanks very much, Jeff.
Thank you, Jen. It's a pleasure to be here tonight, and thank you for everyone attending. Today I'm talking about fibromyalgia, and I've labelled the topic Fibromyalgia, a problem of sensitivity. I think that's the message that I want to get through tonight, and hopefully it will ring true in your various practices when you see patients with this problem. Just some disclosures. I have been involved in clinical trials and medical advice and speaking in regard to a number of pharmaceutical companies that have had links to chronic pain and fibromyalgia. And I have been am still an independent medical examiner for the various insurance companies, law firms in the Victorian government. So my talk is going to be an overview of fibromyalgia. It'll probably take about 30 to 40 minutes, depending on how quickly I speak and how I cover the topics. But I wanted to look at some issues in regard to fibromyalgia. Firstly, what is it? What causes it? How is it? Firstly, what is it? What causes it? How is it diagnosed? And what is the best treatment? And these are sort of fantastic topics, but they can't always be completely answered, but at least that's the area we'll cover. This little sleeping elephant is in a temple in Chiang Mai, overlooking the town of Chiang Mai. He's about 8 foot high, and I like him because I think elephants fit in with the concept of fibromyalgia, and I'll explain that as I go along. If you do a so-called Wikipedia fibromyalgia word cloud, in other words, search Wikipedia for all the terms and names that have been linked to the word fibromyalgia, the one that comes out most solidly is pain. But within the word cloud of all the different descriptors and things that are associated with fibromyalgia, we see things to do with sleep, we see the word chronic, we see disorder, we see tender, we see opioids, we see central, serotonin, dopamine, so we see neurotransmitters, and brain, fatigue, all these sort of words come through that are closely associated with the search on fibromyalgia. The pain dominates, and that's why I guess the word fibromyalgia exists. Myalgia meaning muscle pain, fibro meaning fibrous tissue, just a generic sort of term to describe this condition. Fibromyalgia has many other names, or has had many other names over the decades. Over the last 100 years, there's been different descriptors that now come under the banner of fibromyalgia, fibromyositis, fibrositis itself, even chronic fatigue syndrome, myalgic encephalomyelitis. All of these names can be put under the fibromyalgia banner. And I'm really talking about all of those types of conditions. I'm not talking about myofascial pain syndrome, where muscles become quite tight and sore and little trigger points are found within the muscle bellies and they generate pain. That's sort of a little bit aside from fibromyalgia, but it is linked in many times. I'm talking about these other chronic pain conditions. The fibromyalgia story really goes way back, and even if you go right back into the pre-biblical times, you'll see descriptions in the literature that define a very characteristic clinical picture or pattern of symptoms that makes up what we call fibromyalgia, the so-called phenotype, what it looks like clinically when you see the patient. There's descriptions in the Bible of fibromyalgia, there's descriptions in the writings through the 1800s, 1900s. It was really only in the more latter part of last century that the syndrome or the clinical picture was better defined and made into a more user-friendly sort of condition, if you like, to discuss. So the characteristic clinical phenotype of fibromyalgia, it comprises a number of symptoms. That's my little red button. Number of symptoms. The main symptom, as we said from that previous slide, is pain. The pain is usually widespread pain, affecting all quadrants of the body, often spinal areas, the neck and low back. Pain is the dominant clinical feature, hence the term fibromyalgia. But associated with the pain, most people have significant amounts of sleep disturbance, poor quality sleep, awakening unrefreshed from sleep, and often high levels of fatigue and high levels of cognition change, poor memory or poor concentration. Often these, if people rate the levels of these types of symptoms, they're rating about 6 out of 10, out of 10, where 10 is the most severe symptom possible. 0 is 0, no symptoms. So most of the people who are diagnosed with fibromyalgia have high levels of pain, sleep disturbance, fatigue, and cognitive disturbance. They often have muscle stiffness. They have signs when you examine the patient. You find that the patient is abnormally tender to gentle touch, just pressing with the thumb or the finger or the forefinger, pressing enough to blanch the fingernail, provides about 4 kilograms per square centimetre of pressure. And with that type of pressure, the patient says, ouch, that hurts. There's tenderness that converts to pain. So there's the tenderness through the body, which on pressuring different areas of the body induces pain, more so than normal people or controls or fibromyalgia. So this person here says just a gentle pressing of the mid-trapezius area, ouch, that hurts. Patients also have rheumatography. This is an interesting clinical sign whereby you lightly stroke a finger across the back. There's a good place to see this. Just very gently, and within 10 seconds you'll see a very bright wheel and flare response occur. And we'll see later this links to the release of some of the neurochemicals that are in the pain fiber system, particularly the so-called C fibers, which release a number of neuropeptides, particularly substance P and calcitonin gene-related peptide that make the blood vessels dilate quickly and cause edema and so-called neurogenic inflammation. That's a nice sign in fibromyalgia. So this sort of sign is seen in people without fibromyalgia, but not to the extent of patients with fibromyalgia. And also another clinical sign is muscle stiffness. So patients often have contraction of muscles, cogwheel rigidity almost, depending on the severity, quite stiff and contracted muscles. Another typical feature of the fibromyalgia phenotype is that there's no other clinical explanation. So obviously we have to be sure there's not another condition or disorder that causes this widespread grouping of symptoms and signs. And I'll put to you later on that even though there are conditions that can mimic fibromyalgia, the actual diagnosis of fibromyalgia is not that difficult. If we look at this internet survey from about 10 years ago, it still holds true now, I think. This is 2,400 patients who were contacted by a researcher asking what sort of symptoms do they have at the time. The most common symptom in 100% was muscular pain, fatigue in about 96% of people, and sleep disturbance in almost 90%. So that triad of pain, fatigue, and sleep disturbance was the most reported set of symptoms of all symptoms. Some people also had impaired memory down here, 46%, and or impaired concentration. And if you put those two together, one or the other, that comes in pretty high up here as well. So there's a quadrant of symptoms that I mentioned before. Patients often present with joint pain, and some people with fibromyalgia have little in the way of muscle pain. They actually present to the clinician with joint pain, stiffness and soreness of joints, particularly in the morning. And this might make one think immediately of, oh, is this inflammatory arthritis, such as this is early rheumatoid arthritis. But it can be just a manifestation of fibromyalgia. Headaches are common. There's a common link to migraine in fibromyalgia. Over 50% of patients have restless leg syndrome. Often people have a long-standing history or early childhood history of aches and pains, growing pains, so-called growing pains, aching in the legs, particularly at night, and that can go right back to where they're very, very young. Another common set of symptoms is this one called numbness or tingling, so-called dysesthesia, abnormal sensory feelings in the legs, arms. Again, very common. Over 50% have this numbness and tingling. And this also likely links to some of these neural abnormalities that are pronounced in fibromyalgia. Cramping of the legs. If we get back to these, down to these last two, I'll look at depression first. So 20% of this group reported they were depressed. This is self-reported patients, but 20% were depressed. In other words, the condition doesn't link strong. It links to depression, but it's not as if it's a cause and effect type link. This is sort of the rough average prevalence of depression in the community. More people are nervous, and I think anxiety is a stronger link with fibromyalgia than depression. So just to summarize, pain, fatigue, sleep disturbance, and cognition disturbance in about 90% of patients, really characterizing the syndrome. In any one individual patient, they might have a number of these symptoms. So if you map out on this visual analog scale between 0 and 90, how bad, say, their pain is. This particular single patient says the pain is very severe. There's also fatigue at 6 out of 10. Stiffness, poor sleep. They have some emotional distress. They might have a little bit of dysesthesia, not a lot. They might have some irritable bowel or bladder associated with their condition, not too bad. But these symptoms might slide back and forth according to what's happening in their life, months of the year, or weather change, or activity, or different features that might make these symptoms vary over time. So symptom severity varies even in the single patient. When you see them on one time, they might have a lot of pain. Another time, it might be more trouble with so-called fibro fog, or trouble with thinking. It's quite a dynamic set of symptoms, that's what I mean. The pain severity fluctuates quite a lot. We look to see if there's pain in four quadrants of the body at different times, and also in axial areas, the neck and the back particularly. Not so much the mid-back. So the high pain areas are at the base of the neck and the related trapezius regions, shoulder girdles, and the low back and related pelvic girdle areas. That might be because of the biomechanics in these areas allows for deferred pain from sites when they're sensitive start to cause more symptoms. Pain is often described as burning pain, sometimes dull, like a toothache, sometimes spasms of sharp pain, which can radiate into the limbs. All different types of pain, but burning and aching tend to be common descriptors. This is sort of a chart looking at 5 patients with fibromyalgia, just to show that over time, different people have different patterns of variation in their symptoms. So-called activity of their total fibromyalgia burden will vary over time, over weeks, over years, months, weeks, days, and hours. And studies have been done to look at all of these aspects. Patients in countries where there's very little light during winter have far more fibromyalgia. The Nordic countries have more fibromyalgia than countries that are on the equator. There's variation of activity over the menstrual cycle in females. There's variation over weeks and days. People have looked at fibromyalgia over a 24-hour cycle, and activity is a lot worse in the morning, often eases during the mid part of the day, and only to get much worse, say 4 to 6 o'clock in the afternoon, where fatigue and pain become more dominant. The person with the has to. So these are some patients. Patient number 5 at the bottom has low-level symptoms all the time, not too bad. That's patient number 1. Patient number 2 is this orange patient, pretty much low all the time, but a flare-up from time to time, pain levels or activity levels, the overall burden going up to 5 out of 10. And other patients have much higher levels of pain and burden all the time with fluctuations, flare-ups. And these patients have quite significant intrusion of fibromyalgia symptoms in their life activities. The lower level symptoms are easier to manage. So we've got 2 key symptom groups. We've got symptoms that I've called here central symptoms. They're central meaning associated with the inner part of the neural systems, the brain and the spinal cord. Central nervous system problems. These people have bad sleep. So these symptoms involve bad sleep, fatigue, fuzzy head, poor memory, and emotional distress. So I call those central symptoms. Something's happening centrally to cause those symptoms. But in the periphery, people have amplified sensation. So pain is one sensation that is amplified in fibromyalgia. But there's a lot of other sensations that are amplified in fibromyalgia. There's excessive tinnitus, ringing in the ears, and many people are prone to aggravation of or irritation by noise or light. They wear sunglasses. Sicker means dry eyes. Some people get a lot of irritation and dryness in the eyes with fibromyalgia. People think they might have ocular disease, but in fact it's still sensitivity of the neural system in fibromyalgia. Some people have irritation or irritability in the bowel or bladder, getting up at night several times to the toilet, or bloating, diarrhea, constipation, irritable symptoms. Some people are sensitive to odours, perfumes. Some are nauseated with food, tolerant of drugs, which makes it difficult sometimes to get good drugs into some people to get condition. And a lot of people have pins and needles and tingling, and these people might sometimes be diagnosed as having a peripheral neuropathy, when in fact it's not an organic disease-orientated diabetic neuropathy. It's more a sensitivity type, excessive sensory symptom. So central symptoms and amplified sensations are sort of two parts of the equation. And this is the little dial that gets turned up in fibromyalgia, and if it can be turned down, these things drop down and symptoms drop down considerably. These sensations that are amplified link into other syndromes such as irritable bowel, irritable bladder, restless legs, we mentioned before, regional pain problems such as temporomandibular joint pain syndromes, common links in fibromyalgia. Some people get hypotension, the POTS syndrome, postural-related orthostatic hypotension, chronic fatigue links in here, and chemical sensitivity. And the elephant that I like, here's the elephant with the blind people examining the elephant. Depends on which clinician or health professional this elephant goes to as to what diagnosis they might get. They might get irritable bowel, restless legs, they might get migraine, they might get gastric upset with drugs, they might get fibromyalgia, they might get all different diagnoses depending on the training or the interest of the actual clinician. But the underlying process that links all of these things is called central sensitivity, an increased sensitivity of the neural systems that relate to organs. So we find that people with the diagnosis of fibromyalgia will often have diagnoses of other conditions that link to increased sensitivity. So there's about a 30 to 50% overlap. So if one person's got fibromyalgia, there's about a 30 to 50% chance they'll have chronic fatigue syndrome as a diagnosis, irritable bowel or bladder, regional pain syndromes, etc. So these are all overlapping constructs, but they're not separate. They're linked through this sensitivity, neural sensitivity issue. So if we want to make a diagnosis of fibromyalgia, we draw from our knowledge of those clinical features. And here's this little man saying, you mean that's mine, this body, this battered, sore body is mine. So this person has poor sleep, fatigue and cognitive change, but also widespread pain. And as the years have gone by, criteria to define fibromyalgia have been based on the grouping of these types of symptoms. So particularly widespread pain and widespread tenderness, these two upper rings, were the initial criteria that the American College of Rheumatology put forward in 1980 to define fibromyalgia. Patients were diagnosed by experts, thought to have fibromyalgia, other things were excluded, and the things that came out on the computer, the most common things were the widespread pain and widespread tenderness. Those initial criteria didn't look at all the other characteristic symptoms that we've been discussing, these things, poor sleep, fatigue, and cognitive change. The initial criteria were very useful, but many people didn't examine the tenderness or didn't look at these other characteristic symptoms and put it in the same equation. So the criteria were upregulated or upgraded in 2010 and 2011, and then further in 2016. So these are the latest criteria, if you like. And this is just a way of grouping all of those symptoms that I mentioned. So these criteria are based on the previous criteria. They're all validated. They have high sensitivity and specificity for fibromyalgia. As long as you fill in the boxes, the patient has that sort of numbers in the boxes. So just go through this very quickly. Pain in the last week. This is the first symptom, and that pain should be pretty much the same as it's been for the previous 3 to 6 months. The pain in the last week in the left upper region, the right upper region, left lower region, right lower region, or in the spine. And you just put a tick in each box if they've got pain in the jaw, the shoulder girdle, or the patient fills this out themselves. It's a self-report score actually, and they get a score for each of the pain areas in the last week that they register. So the maximum score here is 19, and that's called the widespread pain index, 0 to 19. So if they've got 12, they put in 12. And we try to make sure the patient has pain in 4 of those 5 regions to ensure this is a generalized problem and not just a single one. So that's another one. That's filled in, and then the patient looks at their other symptoms that make up the central symptoms, the fatigue, waking unrefreshed, cognition, other symptoms. So they score 0 to 3 on some of those, and they get 1 point for others. Headache gets 1 point, abdominal pain, depression gets 1 point. So to get the score for fibromyalgia, you put in the widespread pain index score, A, put in the symptom severity score, B, you add them together. And there's little combinations that will make the diagnosis. Fibromyalgia or not fibromyalgia. If you've got a widespread pain index of over 7, plus a symptom score over 5, get to 12, which is fibromyalgia. If you have a widespread pain index that's less than 7, say down at 4, but they've got high levels of symptoms up here, they can also get to a diagnosis of fibromyalgia. It all looks a bit complex when you first see it, but it's actually quite logical. The patient fills out these scores. You can get this, we'll leave it material at the end of the talk, so you can look at it. And you'll find a lot of people will fulfill criteria for fibromyalgia. The patient must have no other explanatory diagnosis. So they can't have another condition that could cause those symptoms. That's very important. So that's the current criteria for fibromyalgia. There are other criteria around, but these are the so-called American College of Rheumatology criteria for which pretty much all the studies are based on. And since 1990, when fibromyalgia criteria became prominent, there's been about 10,000 different research studies on fibromyalgia using these criteria. So these criteria define the patients in the research that's being done. So diagnosis, tests, there's no test for fibromyalgia. There's no simple diagnostic blood test for fibromyalgia. It's a clinical pattern. It's an identification of the clinical phenotype that we discussed earlier. You have to rule out other conditions with similar symptoms, but diagnosis is usually straightforward and difficult. When one's looking at someone with fibromyalgia, we have to consider conditions that might mimic fibromyalgia. So inflammatory conditions such as rheumatoid, lupus, polymyalgia rheumatica, viral illness may all come into this equation. But you'll recall I said that the patient has to have symptoms for about 3 months of the same sort of severity. So viral illnesses, other conditions can be up with. Metabolic conditions such as hypothyroidism might cause widespread aches and pains. Menopausal hormone changes might cause aches and pains. Multiple fractures, malignancy, or mechanical problems in the spine, referred pain. Degenerative changes in the neck and back might give widespread referred pain and mimic fibromyalgia. So we need sometimes to do a number of blood tests. These are just some of the things: full blood examination, inflammatory markers, maybe check for rheumatoid and PCP levels of rheumatoid arthritis, check an anti-nuclear antibody for a lupus screen, calcium phosphate, CK for muscle abnormalities, vitamin D. If you have a very low vitamin D, you can have things that look like fibromyalgia. Low thyroid can cause it, and low estrogen during the menopause can cause these sort of symptoms. Liver hepatitis, these problems, renal disturbance. So we usually do a lot of tests just to make sure we're on the right track with our diagnosis. Sometimes we need to do imaging, see if there's a single focus that might be causing some mechanical problem, which might mimic the symptoms. Another interesting thing about fibromyalgia is that it's not a diagnosis of exclusion. So you can have fibromyalgia with any other condition, and that's very common. Many people have a condition, musculoskeletal condition, plus the fibromyalgia. So it's not a diagnosis of exclusion. You don't have to do all these tests to prove it isn't something else. You still base your diagnosis on the criteria I mentioned earlier. It's not an exclusive diagnosis. So it is what it is. If the criteria are positive, it finds fibromyalgia, but you have to make sure there's no mimicking condition. Fibromyalgia is very common. Most surveys around the world using those criteria will say in any community about 3 to 5% of the population fulfill criteria. So if you fulfill criteria, you've got quite significant symptoms. In the community, I said about 3 to 5%, depending on which community, have fibromyalgia. Of patients visiting general practitioners, maybe 6 to 10%. In specialists, maybe up to 10%. There's studies done in hospital wards, one in Israel, 20% of patients had fibromyalgia, just in the general medical ward who had heart failure and pneumonia and all. People seeing rheumatologists with aches and pains, we see a lot of fibromyalgia mixed amongst other conditions or by itself. With aches and pains, we see a lot of fibromyalgia mixed amongst other conditions or by itself. And very interesting, people with any chronic illness that's been looked at, be it multiple sclerosis, be it chronic hepatitis, lupus, rheumatoid, any long-term chronic illness, you'll find about 20 to 30% have fibromyalgia, fulfill criteria, fibromyalgia. In fact, at our hospital last year, we found 20% of people attending a cardiac failure clinic had criteria for fibromyalgia. Chronic illness associates with fibromyalgia. Now, this little chart here is sort of like a community look at the age range of people who get fibromyalgia. And it's a sort of a U-shaped curve. Most people are getting fibromyalgia in the mid-years, say 40, 60 is a high rate of fibromyalgia. Still occurs early on in adolescent girls, it's not uncommon. In the elderly in nursing homes, not uncommon. But the majority of criteria-based fibromyalgia in those mid-years. More females than males. Used to be about 9 to 1, female to male, but with these newer criteria that are based more on the self-report of pain and these other central features, it brings in a lot of males. Males aren't as tender as females anyway. But if you've got fibromyalgia, females get more tender than male fibromyalgia patients. And depending on how you assess tenderness, many males used to be eliminated based on their relative lack of tenderness. So that when the tenderness is taken out of the criteria, as in those last 2016 criteria, you're looking just at pain and reports of other typical features, you find the ratio between female and male drops to about 6:1. In the community, fibromyalgia is a spectrum disorder. That's very important. From these criteria, anyone who fills out that chart for the 2016 criteria will get a number. You might get a number of 2, not very many symptoms, or you might get a number of 28, a lot of symptoms. But everyone's going to have be somewhere along the spectrum. We are all in the spectrum. So some people have no symptoms, but they're still on the spectrum. Most of us have some or mild symptoms from time to time, going up and down the spectrum, and many have severe symptoms, and we label that fibromyalgia. So it's not as if it's a black and white diagnosis, a yes or no diagnosis, or once you've got fibromyalgia, you've always got it. You're moving in and out of these symptoms all the time. Some people stay with high levels of symptoms a lot of the time. Others have flares and drop back and have good times. It's a very important concept. It's a spectrum disorder, not a black and white disorder. So we'll see the good times with our patients and see flare-ups. It's a very important condition, has a very high impact. We don't have any specific Australian data for fibromyalgia, but the data from a Management Research Institute from some years back estimated that chronic pain costs Australia about $34 billion per year. A lot of money in treatment and effects. At 3 to 5% of the population, 3% of Australia is 500,000, 5% is 1.25 million. So between 500,000 and 1.25 million persons fulfill criteria for fibromyalgia in Australia. So you're going to see it every day. People with fibromyalgia often get high impact, health burden. They often end up on disability support pensions, work compensation, unable to work, or if they do work, they don't work well, they have presenteeism, health costs are high, drug costs are high, family dysfunction is high, and there's a huge amount of other societal consequences of chronic pain, as you well know. And fibromyalgia is in that bundle. So what causes fibromyalgia? I mentioned earlier about the sensitivity. This is Hans Christian Andersen, the Princess and the Pea. So the princess is sitting on 20 mattresses. A pea is put on the bottom mattress and she still can't sleep because she's too sensitive. The princess and the pea, I think, is a good analogy. So the sensitivity issue is not an absolute disease, organic illness of the system. It's the way the system works, sensitivity. And there's a sensitivity spectrum. We all tend to move up and down this spectrum, as I said before. Our sensitivity levels will fluctuate over the day, over the year, through the menstrual cycle, with weather change. We all have these changes if you look hard. We move up and down the scale depending on any outside stimuli. One of the key stimuli is stress. Chronic stress is a big stimulator of this sensitivity. Different systems that I mentioned before. We all start somewhere with a sensitivity level, perhaps determined by our genetics, or maybe there's been previous experiences in childhood or trauma, etc. Might place us at a bit of a vulnerable risk of sensitivity, and with increased stress, we might cross the threshold that causes the symptoms that we define as fibromyalgia. The pathways to fibromyalgia, about 80% of people will identify a trigger or some stressor that they think is associated with the onset of the condition. This might be a psychological trigger, might be an illness, it might be trauma, but there often is into emotional type. These triggers act on the brain to change the function of brain networks. There's been a lot of work done using functional MRI scanning, showing how the networks that control different pathways, different parts of the brain, altered in people with fibromyalgia compared to people who don't have fibromyalgia, and particularly the networks in the emotional charged parts of the brain that link to pain control mechanisms into the spinal cord. The modulation between the brain and the spinal cord is influenced by the brain network. And this, through an uncertain process, probably from the top down, increases sensitivity within neural systems in the muscles and joints and skin of all of us. If that sensitivity gets to a certain level, other symptoms will come through, such as pain. So stressors linked to change in function of the brain, often through psychological effects. particularly people who get stressed easily, people who have poor coping skills, people who catastrophize easily, people who are not in control, often activate a lot of these pathways that change the function of the sensory filters that normally are operating and stopping us getting too many to the brain. The pathways are linked to genetic effects. So obviously there's going to be a change in the way different chemicals are working in different people. It's been shown there's differences in serotonin, noradrenaline, norepinephrine, and dopamine in people with fibromyalgia compared to those who don't have it. And then there's also sensory inputs in people. Poor posture, poor fitness, these sort of inputs that increase sensitivity in low spinal areas particularly, and mechanoreceptors feed into a sensitized system, and that converts into pain sensation in the brain. So I'm really talking about a top-down type pathway that's operating. Life events cause us to consider what's going on. We appraise what's going on. We have a lot of psychological modifiers that help us work out what to do about a situation. Sometimes our psychological modifiers dampen any consideration of problems. Others will make us distressed, and stress activates, emotional distress activates stress pathways, which are sort of embedded into our brains from ancient times. Those lead to biological responses, changing function of downward pathways, leading to this process of central sensitization in the neural system of the spinal cord. As a result, different which we put together all that file. So top-down is the most important, we think. I mean, people argue about is there a peripheral stimulus for fibromyalgia, but my thinking, and that's what I'm talking about tonight, is the top-down process dominates. Pain-related networks aren't working well. They're linked to emotion and stress. The brain control of pain pathways doesn't work well. The spinal cord, dorsal horn receptors, regions are too sensitive. Low-level sensations now access the pain system. People don't know why that happens. So that's what's happened. Therefore, movement, touch, and control of posture, those sensory inputs from the mechanoreceptor system gain access to the pain pathways that cause pain. So there's no actual tissue damage, it's just things aren't working properly, causing these sensations. And if you look at the pain nerves going down into the limbs, you'll find the pain nerves biopsy are not functioning well. 50% of people have neuropathic or changing the function and structure of the pain nerves in the periphery. These nerves release chemicals, these neuropeptides, which probably do contribute to the pain and other peripheral changes. It's interesting that in the cornea, in the front of the eye of patients with fibromyalgia, the corneal nerves, the sensory pain nerves, are abnormal in fibromyalgia. So this is a widespread change in the pain system, not just sensory system, not just in the pain. But just a few words on treatment. Basically, treatment, we have to combine a lot of different approaches. The treatment, we start at the bottom. Education and understanding is our main plank. Exercise usually comes second, psychological strategies, medication, and newer treatments at the tip. We haven't got a lot of new treatments to talk about, unfortunately. So we have the tree of fibromyalgia: management, education, drugs, exercise, psychology. But it's based on people having good social support, good diet, ideal weight. So you have to have these platforms at the bottom before you can plug these up. Let's talk about education. There's a lot of different strategies to educate people with chronic pain conditions. There's the Path Out of Pain website. There's Explain Pain, Pain Education. And these can be extremely useful. People have to understand what is causing their pain to alleviate their fear of having some underlying condition over and above their fibromyalgia. Stop searching for different treatments and investigation, eye scan, biopsy, surgery. There's some websites and some books that can be referenced. There's quite a lot on the web, obviously, in these areas. The Brain Man YouTube series I find quite useful for people to understand the concept of sensitivity. The Fibro Guide put out by the American Michigan Fibromyalgia and Chronic Fatigue Center is useful. Looks a bit clunky at times, but a bit Americanized, but I think it's not a bad one. It's free online. People can just go through the program, understanding of fibromyalgia, different modules that look at exercise, psychological strategies, explaining drugs, etc. What about exercise? There are lots of different approaches to exercise. It's been shown in studies there's no one particular correct or best exercise. It's just a matter of getting the best exercise for the individual person. It's usually built around a low impact aerobic exercise. Studies out of Scandinavia show that resistance training can be muscle training can be extremely useful as well. So probably combining aerobic low impact with resistance training. This might be walking, swimming, bike riding, gym work, or group activity, hydro pool, etc. They're all very useful and should be top of the list. Pilates and other core muscle strategies are extremely useful. If there are pain generators in the muscles, if there are trigger points, if there's dysfunction in the spine, if there's other problems, they need physical therapy to treat those pain generators in the periphery because they'll just add to the sensory pain. So there's lots of things that can be done, but the bottom line in the long run, self-managed exercise program is extremely useful. So usually we'll say people should be walking, perhaps up to 30 minutes 4 times a week would be pretty good. Stretching multiple regions through the day, strength training a few times a week. Gentle controlled movement is very useful. A study came out earlier this year on Tai Chi. A British study looked at different types of Tai Chi, different teachers, in a short 6 to 8 week course, giving significant benefits over 12 months, better than exercise programs. So that was quite very well done study. A lot of these other strategies are probably very useful, but there's not a lot of good studies around. And factoring all of these things into activities. What about psychology? This elephant saying, I'm right there in the room and no one even acknowledges me. This is the elephant again, fibromyalgia. The elephant in the room is fibromyalgia. So psychological factors, I've got about 5 minutes to go. Is that okay, Jen?
Yep.
Psychological factors in fibromyalgia. Just things to remember, depression does not cause fibromyalgia. It's not just an offshoot of depression, but there is increased rates of anxiety and depression in fibromyalgia. Most people are emotionally distressed. It might be difficult life predicaments. Sometimes those triggering stresses that might have started this process have seemingly gone, but they might still be there, but hidden away. Sometimes that needs attention. People who've got fibromyalgia, if you've got a first-degree relative with fibromyalgia, there's an 8 times risk of having fibromyalgia. And with a major mood disorder, there's 2 times increase in another. So twin studies show 50% risk is genetic and 50% in. So genetic factors do come into these considerations. And if you start talking about life stressors in fibromyalgia, you really open up the Pandora's box. There's heaps of different things that can associate with fibromyalgia. Previous pain problems, family, work, personal stressors, injury, etc. So-called yellow flags are prominent in fibromyalgia. And stress is important. Psychological stress can increase the chance of fibromyalgia, but also trigger the fibromyalgia or flare it up or keep it active over time. So stress has to be managed. Manage the stress, manage the fibromyalgia. And it's often getting back to these coping, control, catastrophization issues that generate stress that can be targeted. Sort of point. Yeah. If there's mood change, that needs to be addressed appropriately, often through medication. Drugs in fibromyalgia, I'll just duck onto this one. So fibromyalgia, there are drugs that are trying to target the different pathways from the brain down to the body. Emotional distress might be adrenergic blockers. For the pain, we do not like to use opioids, pure opioids in fibromyalgia. It's been shown that the opioid receptors are maximally active in fibromyalgia. They're working, the opioid system is working appropriately. You don't need to put any other external opioid system. That's when you start to get dependency problems. Simple analgesics are best, even though they might not do that. For sleep, low-dose tricyclic medication like amitriptyline NDEP is very useful in low dose for the build-up of the chemicals that are overly expressed in fibromyalgia, particularly glutamate, which is high in fibromyalgia brains. That's where the pregabalin lyrica and gabapentin neurontin target. They decrease the glutamate. And studies have shown that if you decrease the glutamate in the brain on fMRI scans, you'll get a good clinical response. The NMDA receptor antagonist memantine can also be helpful. That's used in Alzheimer's disease as well. Pain drugs that modulate the connection between the brain and the spinal cord, so serotonin and noradrenaline reuptake inhibitors, that's duloxetine, Cymbalta or milnacipran johnsia, can be useful. Drugs that are so-called atypical opioids, they boost up noradrenaline as well as having milder opioids that can be useful. That's tramadol and Palexia tapentadol. And there's other drugs that target different pathways that may be relevant. Medical marijuana fits into this cannabinoid pathway. So far, we haven't got a lot of evidence in that area. I think I've said that. So drug treatment, the overarching principles are to treat any comorbid problem, optimizing the general health of the individual, getting people to be physically active, conditioned, and get rid of obesity, help the emotional distress, implement education, psychological health programs. If drugs are to be used, they should be pain modulatory drugs, and the principle is to use low doses and build slowly, avoiding the pure opioids such as Oxycontin, those type of fentanyl, and reassess regularly. In regard to treatment of fibromyalgia, we have a 30-50 rule. Generally speaking, any drug, for instance, 30% of people get a 50% improvement in pain, and 50% get a 30% improvement. 50% improvement in pain is really good. They get back to work. 30% is very useful. If you don't get 30% pain improvement, that's not that useful, and 50% don't. So a lot of people with drugs don't achieve the outcome we want. Many people don't respond, and side effects limit. Just a few quick reminders. Fibromyalgia is very common in osteoarthritis pain. Fibromyalgia is very common in rheumatoid, lupus, bowel inflammation, hep C, any chronic illness. Fibromyalgia is very common. Fibromyalgia is common at the menopause. Aches and pains are as common as hot flushes. This is the fibromyalgia mechanism. So a lot of people in the menopause will be after injury, neck, back, or arm, after work injury or motor car accident. Fibromyalgia is very common. Local sensitization or generalized sensitization is common. These are big red flags for fibromyalgia. So fibromyalgia is in many rooms. I tell people with fibromyalgia to educate yourself, understand sensitization, exercise daily even if it seems minimal. Hurting doesn't mean you're harming yourself. Try to socialize. Being alone is not good. Don't withdraw, keep involved. Social networks are very important. Try to identify stressors and get professional help as the situation demands. Often you'll need a team of people to help, and the team should speak the same language and interact with each other. Use medication cautiously. If there's a drug to be used, it should be work in 1 to 2 weeks. If not, you have to change. Be aware of magic. There's a lot of magic treatments around for these types of conditions. Be wary of snake oil people and remain positive. So I've just gone through briefly fibromyalgia, an important elephant in many rooms. This elephant is too sensitive. There are characteristic symptoms. It is a common condition, very high impact. There are central mechanisms that drive fibromyalgia. It's a spectrum disorder, so a lot of people move up and down that spectrum. Best treatment is still evolving, and the individual patient has to learn how to know themselves and learn self-management skills. I'll just finish there, Jen, and look for some questions.
Great. Thanks very much, Geoff. It's really such a fascinating condition. I've heard you speak before, but it really is really fantastic to get that sort of great overview of fibromyalgia. Sorry about that. Geoff, we've got a couple of questions, and to everyone else, I ask that you type in any questions you may have now, we've got about 9 minutes left of our webinar this evening. Geoff, you probably covered this because it was a question that came in fairly early in relation to how you differentiate between chronic fatigue syndrome and fibromyalgia. So with regards to what you outlined as the signs and symptoms, do you think that was a sufficient explanation to differentiate between those two conditions?
Well, yeah, I think most people with what is called chronic fatigue syndrome have criteria for fibromyalgia. I like using fibromyalgia as the term because there's far much more research and sort of a better mechanistic sort of understanding of fibromyalgia than chronic fatigue. For many years, chronic fatigue's been thought of being a viral illness or something that people keep searching for. It has to be there somewhere. I think fibromyalgia, you sort of stand back and look at the whole elephant a bit more. So there are people who do have severe fatigue without much myalgia, much pain. So maybe that's a slightly different beast. But most people have the myalgia and the fatigue together. I like using
that. You mentioned the importance of exercise in any management approaches. There's also a question here about whether it's common to see people with a minimal exercise history who may have fibromyalgia.
Yeah, people who are sort of chronically unfit or deconditioned are more prone to get fibromyalgia. That's true. But you can get athletes that get fibromyalgia. I mean, Alistair Lynch, he's one of the guys who gets chronic fatigue. He was a league footballer, playing league football, still with that severe fatigue and myalgia. I've seen Olympic canoeists with fibromyalgia still can perform, but they're pain and fatigue. So, but in general, people with conditioned bodies, aerobic exercise. In fact, we did some studies in Melbourne years back looking at people going to a gym. In fact, we did some studies in Melbourne years back looking at people going to a gym 6 hours a week, people not doing that exercise, people with fibromyalgia. It's like a spectrum. It's a curve from one end to the other in regard to symptoms. So exercise is extremely important.
And Geoff, there's a question about any information about biotoxins as a cause or contributor to fibromyalgia, biotoxins such as mold, which is common in water-damaged buildings.
Well, no, the answer is no. I'm sure there's a lot of people get chronic pain, concentration problems, fuzzy head, fatigue, can't sleep, and they're in a situation and they blame the environment. It might be, sick building syndrome, or it might be, a big windmill, on the farm next door. It might be Agent Orange. There's a whole heap of things that are possible biotoxins that have been looked at. But I think it's more the way the neural systems get activated by more the psychological in the true sense of that word. I think that activates all of these pathways very powerfully. And a lot of these biotoxins never end up sort of telling us much. But if there's something there, let me know.
Okay, we don't have any other questions at this stage. So if anyone has got any last-minute questions, please type them in the chat box now. But otherwise, assuming that's the end of the questions for this evening, Geoff, I'd like to once again thank you very much for your presentation this evening. I'd like to thank everyone for joining us tonight. The exit survey has come up on your screen, so I'd be very grateful if you could take just a moment to complete that exit survey. And on that note, I wish everyone a very good evening and also a very good holiday break. So best wishes to all. Thanks very much.
Thanks, Jeff.
The conference is now in private host conference mode.